everybody, this is Dr. Sadler with Creating Future Nurses, and today we're going to talk about diabetes mellitus. Okay, so when we're looking at diabetes mellitus, let's go back and think about what it is and what's happening. And I always like to think about what's happening in the body to help us understand what's going on. So first of all, we have the beta cells that are in the pancreas. The beta cells is what creates the insulin. And then what does the insulin do? So I like to think of the insulin as a key. It's a key to the cells because the glucose, the food, the glucose has to enter the cells to be used and break down for energy. And so the insulin serves as a key to allow that glucose to be able to enter the cell. So it opens the cell so the glucose can enter and break down and be used for energy. If that glucose does not enter those cells to be broken down for energy, then it starts to build up in the blood. And so then that's when you get your buildup of blood glucose levels. Okay? So now we have type 1 and we have type 2 diabetes mellitus. So type 1, the beta cells are producing extremely little to pretty much no insulin. So there's no insulin available in the body at all. Whereas with type 2 diabetes mellitus, the beta cells is producing a little bit of insulin. However, either A, it's not enough to meet the body's needs, or the little bit that it is producing, the cells aren't sensitive to that insulin. And so that's where you get some of your oral diabetics that can help, make the cells sensitive or stimulate the body to produce more insulin. So our type 1 diabetes mellitus, they call that insulin-dependent diabetes mellitus or juvenile diabetes mellitus. So insulin-dependent because type 1 is definitely going to be on insulin, whereas type 2 is non-insulin dependent diabetes mellitus. So those individuals, I've even run across some type 2 diabetes mellitus individuals that can control it with diet and exercise. However, a lot of times they may be on an oral diabetic, whereas a type 1 can't use an oral diabetic. But a type 2 can use an oral diabetic. But depending on the severity and how critical their diabetes is, they could potentially be on insulin as well. But definitely your type 1 is going to be on insulin. Okay, so some signs and symptoms you're going to see in both of them, the 3 Ps, I call them. The 3 Ps, that's your polydipsia, your polyphagia, and your polyuria. When you say poly, remember poly, use your prefixes and suffixes to help you to start to understand what different medical terms are. So anytime you see the phrase poly in front of a word, that means excessive. It's more than. So polydipsia is excessive thirst. Polyuria is excessive urination, and polyphagia is excessive hunger. So those are some signs and symptoms you could potentially see in your patient with diabetes mellitus if their blood glucose levels are not controlled. Rapid weight loss, irritability, weakness, fatigue, nausea, vomiting. These are all some things that you could potentially see in your patient with type 1 diabetes. Now, most of our patients with diabetes actually have type 2 diabetes due to family history or different lifestyles that have caused them to develop type 2 later in life. And so individuals with diabetes mellitus could have poor wound healing is an issue, blurred vision, weight loss, fatigue, numbness and tingling in the feet. A lot of our diabetic patients can develop neuropathy. And so that's why it's so important that you educate your individuals or your patients that they should never walk around barefoot because of that neuropathy, they could step on something and not know it. And so then by the time they realize it, they have a major wound that has developed that could have been prevented. Also, that's why it's important to educate them to never walk around barefoot, because for that same reason, if they didn't see it or realize that something was wrong, they couldn't take care of it right away. So never walk around barefoot, always wear proper fitting shoes, and always, walk around with shoes on. Even if you're in your house, you could still step on something and not realize it. So those are some important things you want to make sure you educate your patients on that have diabetes mellitus. So let's take a look at a few complications associated with diabetes mellitus. So we have hypoglycemia, HHNKS, which is hyperglycemic hyperosmolar non-ketotic syndrome, and then DKA, which is diabetic ketoacidosis. So let's start with hypoglycemia. So the American Diabetes Association says that hypoglycemia is a blood glucose less than 70. So typically a normal blood glucose is considered to be between 70 and 100. So if they're under 70, that means they're hypoglycemic. And so we need to, interventions need to be put in place at that time. Different things can cause a person to have become hypoglycemic. And a lot of times a patient can tell by their signs and symptoms that they're starting to experience a low blood glucose, especially if they've been diabetic for a while. But causes could be overdose in insulin, so you've taken too much insulin, or maybe you skipped a meal or delayed a meal or something like that can cause you to become hypoglycemic, or unplanned strenuous exercise. Exercise can lower the blood glucose as well. So you need to make sure your exercise is planned so you can plan your proper snacks during that time so that you don't become hypoglycemic during exercise. So some signs and symptoms they might see. Like I said, a person can probably feel their blood sugar starting to decrease. So if a patient tells you they feel like their blood glucose is dropping, and you want to check that immediately, because they can have headaches, impaired vision, they become hungry, sweating, dizzy, shaky. All these are some signs and symptoms that their blood glucose level is dropping. So if you check a patient's blood sugar and it's less than 70, you want to implement something right away. Something needs to happen. And so different patients, I've had patients at 60 that might be getting a little incoherent, and I've had patients at 30 that are sitting there talking to me as if nothing is wrong. So these are just, some signs and symptoms that could potentially happen, but everybody in how they're going to experience those signs and symptoms is going to be different. It doesn't matter. If they're hypoglycemic, you still need to implement some measures. Now, if they can swallow, if they're coherent and they can swallow, because you don't want to put anything in their mouth if they're not able to swallow or not with it, because then you can cause that person to aspirate. So if they can swallow, you can do 3 glucose tabs, or you can do the equivalent with the glucose gel. They have the glucose gel that you can put in as well. A lot of times people, just purchase those at the drugstore and carry it around with them. If you don't have the glucose tabs or the glucose gel, you could still do juice, or orange juice or something like that. You can do skim milk. Skim milk is high in sugar, so you can do that as well. A cola. If you did candy, it'd have to be like 6 or 7 of the like the lifesavers or something like that. It'd take a lot of those lifesavers to bring a person's blood glucose level back up to where it needs to be. If they are not with it, if they can't swallow, then they have the IM intramuscular glucagon that can be injected. So if a person does carry an intramuscular glucagon with them, then obviously you want to make sure their loved ones or who they're with knows how to use it, because obviously if they're not with it, they're not going to be able to administer it to themselves. So then their loved ones need to make sure they understand how to use that. So if they're not with it. Now, if they're in the hospital, they may order D50W IV if they are in the hospital or something like that. But understand, something needs to be done immediately to get their blood glucose level back up. So whatever it is that you do, whether you give them the juice or the glucose tabs or whatever it is you do, you want to recheck their blood glucose in 15 minutes to ensure that it's starting to come back up. Once you've got it stabilized above 70, then you can give them some protein to, help maintain. All right, let's look at our HHNKS and DKA. So HHNKS is mainly in our type 2 diabetes, and DKA, diabetic ketoacidosis, is in your type 1 diabetes mellitus. So let's explain why. Remember, going back to what we said with the type 1 and type 2. Type 1, they're not producing any insulin, whereas type 2, they're producing a little bit, but it's not enough to meet the body's needs. So with type 1, since they're not producing any insulin, then that means no glucose is getting into the cells. So since no glucose is getting into the cells, the body's going to continue to do what it do and keep breaking down. It doesn't have the glucose to break down, so then it's going to start breaking down fat and protein. Once it starts to break down fat and protein, the body's going to produce ketones. That's where you get your diabetic ketoacidosis. It's going to start producing ketones. Okay? Whereas in type 2, remember, those individuals produce a little bit, but it's not enough to meet the body's needs. So they're not going to start producing ketones as they do in diabetic ketoacidosis. So that's why you have the differences there. HHNKS type 2 mainly and DKA type 1 mainly. Your glucose is going to be very high with both of these. In fact, in HHNKS, they could potentially be over 600. It's going to be really high in both situations. So if you don't take your insulin, obviously your blood glucose is going to go extremely high. Illness and infection can cause your blood sugars to go high as well. So when you have a patient that's ill or has some type of infection, you want to make sure they're checking their blood glucoses regularly, because illness can cause your blood sugar to go up. Overeating can cause one of these issues. Severe stress. So when I say severe stress, I'm talking about surgery or some type of serious trauma or a serious emotional issue can cause this issue to happen. So what kind of things are we going to see? Again, we'll see our 3 P's. Remember the 3 P's: polyphagia, excessive hunger; polydipsia, excessive thirst; and polyuria, excessive urination. You can see in both of these things. Fatigue, blurred vision, nausea, vomiting, abdominal pain. Now, here we start to switch up on some of the signs and symptoms we might see. With HHNKS, they might have the focal seizures. But in DKA, you're going to see the Kussmaul's respirations and the fruity breath. The Kussmaul's respirations is an increase in the rate and depth of the respirations. And so the reason you have the Kussmaul's and the fruity breath in the DKA is because of the ketones. So you're having the Kussmaul's respirations. They're trying to compensate and get rid of that acetone. And so that's why you see it in DKA, because they have ketones. Remember, we said HHNKS, they don't have the ketones. So with DKA, they're trying to rid the body of the ketones. And so the acetone smell is coming off the body. And so that's why you have that fruity breath, because of that acetone that they're trying to rid the body of. Treatment is going to be the same. Both of their blood glucoses is going to be very high. So we need to give them insulin to decrease that blood glucose. Because it's going to be so high, it's likely going to be IV. The only IV insulin you can administer is regular insulin. And so that will have to be done by a registered nurse, because that's going to be IV, because their blood glucose is going to be so high, we need to get it down. So it's probably going to be regular via the IV. IV fluid for rehydration, because remember we said they have polyuria. So with polyuria, what are you at risk for? Dehydration, right? And so all the signs and symptoms that go along with dehydration. Also, education. Education, like we said, if you're sick or ill, then you need to be checking your blood glucose more regularly. You need to make sure you're taking your insulin properly. Educating on diet. So we need to educate them how to prevent this from happening again. Okay? So, and also our electrolytes are going to be off as well because you're losing all this fluid. So monitoring your fluid and electrolytes as well. So these are, you know, some complications that you can have when you have a client with diabetes mellitus. And so that wraps up our discussion on diabetes mellitus and some of the complications. So if you enjoyed this video and you would like to see some other videos like it, then please consider subscribing to my YouTube channel. Thank you and have a great day.